Hello, everyone, and welcome to Community College of Philadelphia's World AIDS Day panel discussion. So I apologize for our late start. We're having some difficulties with the computer software here, but we seem to got everything under control. And unfortunately, some of our panelists got, called away for work, so we are a little short-handed today, but we're still going to have a great conversation. And I'm just going to start by bringing out our first guest. So welcome, Deja Lynn Alvarez. So Deja, hey Deja. For everyone who is watching, Deja is the Director of Community Engagement at the Philadelphia AIDS Consortium and World Health Infrastructure and the LGBTQ Care Coordinator at the Department of Public Health. Hi Deja, thanks for joining us.
Hi, thanks for having me. Thanks for doing this today.
Yeah, we're glad to do it. We always do something for World AIDS Day, and with the pandemic going on, we thought it would be great to have some sort of online panel discussion because there's just so much information about HIV and AIDS that is not really getting out to a lot of people. I think there's a lot of people who still don't understand really what HIV is and the stigma that surrounds it. So we had two other panelists, but because all of our panelists work in the health field and do testing and educational outreach, I believe the other two just got called away for emergencies. So we're just going to jump right in. And I hope Deja doesn't mind doing some heavy lifting for us by holding down the panel. So we're just going to jump right in with our first question, which is, what exactly is HIV and how is it different from AIDS?
So HIV is the virus that causes the symptoms which are known as AIDS. So the difference is HIV is the virus itself, and AIDS is more so the symptoms and the effect of HIV.
Okay, so it's similar to how like SARS-CoV-2 is the virus which causes COVID-19.
Yes, exactly.
Great.
Yep.
Okay.
Perfect.
So what is one thing that you wish more people understood about HIV or AIDS, and what pervasive myth about HIV/AIDS do you wish would go away?
One thing that I wish more people understood about HIV/AIDS. I think that I think I would like for people to understand it's not a gay or an LGBT disease or virus or illness, and that it doesn't have anything to do necessarily with the person's lifestyle, which I don't like to use that term because being a very loud, proud trans woman, I don't feel like I'm living a lifestyle. I'm just living my life. So I think I would like people to recognize that. And then I think a pervasive myth that I would like to go away. That if somebody does have HIV, that they cannot live a full, healthy life at this point, just like all the rest of us can. Somebody who has HIV, that does not necessarily mean it's going to shorten their lifespan or that it's going to change their life in such a dramatic way that they can't continue to live it in the way that they're used to.
It's funny that you picked those two things because I think they almost go hand in hand because as we have more advancements and more treatments, I think a lot of the outreach being done is happening within the LGBT community. So a lot of LGBTQ folks have access to medications and access to knowledge, and they understand how the virus works and how it's transmitted. So rates in the LGBT community are going down. We have other at-risk populations where risk is actually going up outside of the LGBT community. So both of those things that you hit on are kind of interlinked.
Yeah, absolutely. In both of my positions, what I often see amongst cisgender heterosexual individuals is when they come in and say that we give them a test, they're now newly diagnosed, they're completely shocked. There are still a number of folks that still believe that it can't happen to them. But on the flip side of that, there's still a number of LGBTQ individuals that still believe that it can't happen to them. But I see it more so in the cisgender heterosexual folks that come in and they're, well, I don't sleep with anybody who's bisexual or anybody who's gay, or so they just assume that it can't happen to them.
Yeah, I think that's also part of like the hubris of like thinking that you're invulnerable. I think that's also something with like younger populations too. It's like you're young, I can do anything, I'm invincible is kind of the feeling when it comes to those kind of things. And then you get kind of this news and you're like, how could that have possibly happened? I didn't think it would happen to me.
Yeah, I've seen it. I have a lot of young folks that are clients, patients, and they the most heartbreaking for me is, they start coming in to one of the clinics or something at 15 or 16, and they haven't even opened up to their family yet about their sexual orientation or gender identity. And then you're seeing them for a couple of years, and then all of a sudden they show up at 17 and you give them another, test, which you try to test them regularly and you try to teach them about things. And then now their test is positive and they haven't even turned 18 yet. Mm-hmm. And that's what it's from. It's like, well, I thought that he really liked me and I didn't think, that I was really at risk because I wasn't sleeping with a whole bunch of people. And a lot of folks think that it only happens to promiscuous individuals, and that couldn't be further from the truth.
Yeah, absolutely. I feel like people think, well, this person's my friend and they're not promiscuous, and so they're probably not carrying any sort of STI or STD. And I think people think the same thing with like pregnancy as well. It's like, well, you can't get pregnant on the first time. There's so many myths around these things because we don't have comprehensive sex health education in this country. And a lot of places can't even really talk about sex. It's abstinence only.
Right. So we do have comprehensive, sexual health education in this country. The problem is it's not as readily available and it's not as readily provided as it should be because we're still such a religious-based society that goes off of the old notion that, oh, well, if you talk about it in front of them, if you talk about that stuff in front of a kid, it's going to make them want to go do it. And I do a lot of speaking engagements and educational forums and stuff. And I always say when people say that to me, well, I don't want to see that on television. I don't want my child watching that on television. I say, well, how old are your kids now? Some of them, in the audience may go, oh, they're 20 something. They're 19, 20. Oh, well, I'm sure they've seen several dozen doctors on TV and they're not a doctor, right? So that, while that's kind of a little bit of a zinger at them, but it's also to kind of give them that jolt, like, oh, wait, maybe that's true.
Yeah. I mean, plus we know so much. Yeah. We like actually have the data to back this up. Like we know that when Colorado made it so that anyone over the age of 16 could have access to sexual health services without notifying a parent, their teen pregnancy rates went down. When when Mike Pence was governor of Indiana and he cut Planned Parenthood and cut sexual health services, an HIV epidemic surged in that state. So like we know that taking away these services, we know that taking away these services leads to worse cases of or higher surges of STIs and teen pregnancy, and we know that the abortion rate goes up. And people talk about abortion rights, and it's like if you want to stop abortion, make access to contraception and education better. And that's not just like a political viewpoint. That's backed by studies and by information that we have from years of research and from actually doing it.
Well, we've literally politicized these things to the point to where people are so set in their views about it. It's very hard to break through to the groups of people that are receiving these messages in their churches and in their homes and in their family settings. It's very hard to break through to them to get them to understand that the way that you're viewing things and the way that you're doing things is actually putting you, your children, your other family members at a higher risk. When we talk about high-risk population, do you know the high-risk population that we don't talk about? The people that are not listening to the public health experts that are giving them the actual scientific data, the people that spend more time listening to what's going on in their church than they do what's going on with their children.
Mhm.
Those are high risk populations as well. People talk about, the trans community is the highest risk population, or the Black and brown communities are the highest risk populations. One of the highest risk populations are basically the science deniers, as I call them. They
Mhm.
don't want to pay attention to the science or the facts. They want to pay attention to some old teachings that there is no actual data for.
Yeah, and there's also like so many churches that are doing fantastic work in that, and it's like those churches that refuse to do that are giving other churches a bad name. I was actually just talking about this with a student the other day. I feel like anytime we talk about LGBT issues, people are like, you're anti-conservative, you're anti-Republican, you're anti-religion, you're anti-this, and it's like, this is not a political thing. We're just talking about like what is needed to stop an epidemic. We're talking about what's needed within a marginalized community. And like, those are not inherently political things, but because we politicize them, we make it a thing that is kind of across party lines. Talking about those things is sometimes seen as political. And as you know, as a nonprofit organization, we're not talking about politics. We're not allowed to take political stances. And so it's like, I'm not taking a political stance. I'm just saying, like, from what this community needs, this is what we need. And regardless of what party you're with, we need a politician that's going to stand for these things. And so it's like, I don't care about party lines. I need a politician who cares about the LGBT community and cares about the issues that affect our community. And that doesn't matter what party you are. Which I'm sure you know, working at the nonprofit.
Don't even take me down that road. Do not take me down that road.
Before we go too far down the tangent, let me jump into the next question so we stay on the topic of HIV and AIDS. So,
it is. I will say
it's interrelated too. I know
it is, and we're experiencing a pandemic of a different sort right now. But what we are seeing, the results that we are seeing, the lack of crossing the party lines, the lack of looking at it just like you said, it doesn't matter what side of the aisle you're on. It doesn't matter if you're Republican or Democrat. What you should be looking at is this particular pandemic, how it is affecting people, who are the most affected by it. But instead, it's politicized. And what we're seeing now are the direct results of politicizing all of these things: HIV and AIDS, COVID-19, teen pregnancy, women's healthcare, all of that being politicized. That is what continues to prevent us from overcoming all of these obstacles. And instead of looking at it from a human perspective, from a public health perspective, we're looking at it from a political perspective.
Yeah, and it's almost like we didn't make this political. We're not the ones who drew the line in the sand. We're just asking for like people to care about this topic, to care about our community. Which also, like you mentioned, like having a pandemic right now, I think that there's definitely some parallels between the pandemic we're experiencing now, but there's also some key differences. And one of the key differences that I was actually just having a conversation about the other day is the issue of consent. And so with HIV, if people are engaging in high risk activities, they're putting themselves at risk. Whereas with coronavirus, if you're putting yourself at risk, and then you're not wearing a mask, you're putting everyone around you at risk. So there are a lot of people who were fresh out the gate were starting to like compare coronavirus to the AIDS epidemic. And a lot of scientists were like, it's not the same and we can't treat it the same. And then a lot of HIV folks were like, ethically, it's also not the same.
Yeah, and it's not. I understood where the folks were coming from that survived the original AIDS crisis and watched everything that went down. I understood that stirring up some old traumas for that, but it's definitely different. You're not running around breathing HIV onto people. Literally, the air that you breathe is what can infect you with COVID-19, which, if you go to church and you sneeze, you probably, run the risk of infecting the 20 or 30 people that are directly around you because it's a 6 to 10 foot range of particles.
With poor ventilation too.
Yeah, but I completely understand where they were coming from because they felt as though this pandemic was being ignored as the Reagan administration ignored the AIDS crisis in the early 80s, how it was ignored and it was dismissed in a way because of the population that it seemed to be affecting.
Yeah, and that seems to be a common thread as well. Like when we're looking at epidemics and pandemics, because in addition to looking at how the Reagan administration handled the HIV epidemic by ignoring it for 3 years because they didn't care that LGBTQ people were dying, the same thing happened when the bubonic plague came to San Francisco, and the mayor of San Francisco completely ignored it because the only people dying were Chinese immigrants, and they didn't care that the Chinese immigrants in Chinatown were dying, and they basically pretended like it wasn't a big deal and ignored it as a bunch of people were dying from the plague. So it's like this, and I think there's articles about the Spanish flu, about people like refusing to wear masks. So it's like, it feels like history keeps repeating itself over and over again. I think people don't know how to respond to a pandemic or an epidemic, especially when it's something that's not tangible.
But do you know what is still the same as it was through all of those other pandemics? The one common denominator?
What's that?
Who's in power? Our power structures have not changed enough we're starting to see a change. We're starting to see a change.
Mm-hmm.
But who is in power is directly correlated to how we've handled all of those things. And it's the reason why, with a pandemic in the year 2020, we are still handling it very similar to the bubonic plague, to the AIDS crisis, to the Spanish flu, to the flu that attacked in the early 1900s. And that is...
it's because you have someone at the top who's not listening to science. That is the common denominator. Like, whether it's the mayor of San Francisco or the president of the United States, like, whoever's at the top needs to believe in scientists and listen to what scientists are saying. Because all of them had scientists saying, you need to say something and do something about this.
But the thing is, all of them still look the same. We're seeing a change in the power structure, but it's slow and it's a hard climb and a hard fight. But right now, the folks that still make the decisions look very much as they did in 1800 and in the early 1900s and in 1983 and 84 and 85. And so I think that's part of the issue there too.
Absolutely. So next year actually marks the 40th year since the CDC first reported cases of what would later be identified as AIDS. What do you feel has been the biggest advancement made in combating this pandemic so far?
The biggest advancement in combating this would be treatment. It would have to be treatment. And it would have to be that we have discovered medications that, when combined and taken regularly, can all but cure HIV.
Yeah.
So it would absolutely have to be the treatments for HIV, I think, are that's the most progress, because we see so many people now. If you were diagnosed with HIV in the early years, it was an automatic death sentence. Automatic.
Mm-hmm.
There was no hope. There was no dreams. There was no way that you were going to be able to beat this. You knew that you were on borrowed time. And now we're not seeing that, as long as we can keep folks on their regimens, on their medications. And, even as things started to advance slowly over the years, there were the cocktails where you would have to take 3 or 4 different pills 3 or 4 times a day. And it was very hard to manage. And now we're down to, like 1 pill a day. Yeah. And that pill may have like 3 different medications. So what used to be a cocktail is now a cocktail, but in a single pill form.
Yeah, absolutely. I think also, like, the idea that those medications can now be used for prevention purposes with the advent of PrEP. I think that's probably the biggest thing for me, because I think that was one of the biggest things that's come out on the prevention side of things. Now that you have pre-exposure prophylactics, you can now take a daily medication to prevent your own, to prevent yourself from contracting the virus. And also with the advent of the really effective antiviral medications, you now have people who are undetectable. And now that research has come out saying that if you're undetectable, you can't transmit the virus at all. Undetectable equals untransmittable. U equals U is the advertising campaign for that. That's huge. That means that, like, if you're in a relationship with someone who's HIV positive and undetectable, and you're taking PrEP, the risk of passing the virus from one partner to another is basically zero. It's like statistically it's zero.
Yes, absolutely. If you're both taking your regimens, it really is.
We
Yeah,
actually have some audience
that's amazing.
questions. I love this. Okay, so Aaron asks, can you talk more on treatment and prevention because access to PrEP is expensive without insurance?
Oh, I'm glad you brought that up. So part of what I do is find ways to work within the systems that are put in place to prevent people from getting access to these things. So there are a lot of different workarounds at this point. Um, Unfortunately, not everybody has access to those workarounds. It took a lot of work. It took a lot of people that are higher up than me to be on board with me. Um, and to also be looking at this from a public health perspective, and that at the end of the day, our jobs should solely be making sure that everybody and anybody that wants or needs this stuff can get access to it. That your financial situation should not prevent you from being able to access this medication. Your housing situation should not prevent you. Like, one of the things we did at my office was we set up.
Oh, Deja, did we lose you? Right. Looks like we're having continued technical difficulties. Let me just text Deja, see if you back?
Yeah.
Oh, you're
I don't
back.
know what happened.
Awesome. You just
Okay.
froze. You started talking
Sorry
about
about
some of the local organizations that were doing some stuff, and then you froze. Oh, and now you froze again. Oh, there you are. You're back.
I wonder what's going on. Everything is connected.
It was probably just like a internet slowdown for a second.
Well, they keep saying since so many people are accessing the internet during the day more so than what was normally happening, that they're having problems keeping up. But can someone reflect that in my bill, please? But so treatment and prevention, absolutely. It's up to the organizations, like what we have done here. Like we even set up a program for folks that are housing unstable. So if they don't have a steady place to live, their medication is delivered to us every month. So that way, no matter where they are, they know they can come here and get it. And if they have to come every day to pick it up in the morning, that's fine. If they can take a week's worth, or if they want to just take the whole month, that's fine. And then we also mail medications out. So people are moving around and they have an address that you can mail it to, then you can mail it to them. Organizations just have to make the effort. You have to get a little creative in how you do things. Because unfortunately, most of our systems are not set up for people to easily access this stuff, whereas it should just be readily available to everyone. No one should have to figure out a way to circumvent a rule or a policy or a procedure, that if we just give them the medication, that will help combat the pandemic that is still HIV.
Yeah, this is another thing where I think it kind of is a detriment that we really only talk about this in the LGBT community, because a lot of the places where you can get PrEP for free without insurance are community health centers for the LGBT community and organizations that specifically serve the LGBT community. So it makes it so that other high-risk populations don't have access to PrEP if they even know about it, because the education hasn't reached their community.
Yeah, absolutely. We, in particular, we apply for different grants, and we find different revenues of funding that bring us in some additional money, so that if we can't find another way, then we will pay someone's copay for it, or we will, help them out for a few months until we're able to get some other situation worked out. You have to be really creative, and you have to be willing to really build relationships, because that's the other thing. Even the funding for HIV has been set up in a way where organizations are competing with each other for the funding, instead of working together for the good of people. And so if everybody is fighting over trying to get the same funding, they're not sharing information, they're not sharing resources, they're not sharing those things that are invaluable to other people and to other organizations that would be able to help, their clientele. It doesn't matter. Like working at the Department of Public Health, there are a lot of times that I find out some of our patients that have been longtime patients are now with one of the CBOs, one of the community-based organizations. And as soon as I find that out, I reach out to the patient and I don't say, hey, why did you leave? I say, hey, just check on you, making sure you're good. I'm under the understanding that you're getting your care somewhere else. I'm really glad you're still getting your care. Just want to make sure you know that if you have any questions or you need any help with anything, you can still come to me. And I think that's really important too. We don't look at it as though, oh, that one is stealing my clients, that one's stealing my patients. No,
Yeah.
that one is helping taking care of an individual. And as long as that individual is getting their care, at the end of the day, that should be the most important. But that can be hard for an organization as a whole to look at it that way because they're fighting for the same funding sources. So therefore, they're like, oh, if this person gets that person, then they're getting the funding for that person. And if you...
But there's like a waiting list of people who need these services. So go find someone else who needs it.
Listen, right, like, come on. And I find, honestly, if you don't focus on that, if you focus on the work itself and on the public health perspective, it's all going to work out in the end. You might lose a few dollars, but that's not what this work is. But that's not anybody who's working in public health. That is not what you're supposed to be focused on. Yes, you do have to keep that in mind at times to make sure you have some money coming in. But at the end of the day, it's supposed to be about public health. So if you look at it from that perspective, I feel like things just kind of work themselves out. And at the end of the day, you're also helping to reduce the number of folks that are not undetectable. You know what I mean? So
Yeah.
if you're able to keep people undetectable, you're reducing the number of HIV infection rates. That's, that's what our goal is.
Absolutely. I mean, I feel like there should be so much funding going into this, especially because it could end an epidemic if we're able to really get everyone to an undetectable level.
Yes,
absolutely. It just completely halt spread. Which actually reminds me of one of the next questions. So as you know, several treatment and prevention options are in development as scientists search for a cure and a vaccine for HIV. What forthcoming advancements or research are you most excited about?
This was my favorite question when I read these questions. I was like, oh, I can't wait to get to this question. So the advancements there are now injectable treatments coming down the pipeline. Unfortunately, our FDA is very slow moving and they tend to hold up advancements. Again, because the FDA is politicized like everything, all of our other systems. But so we have treatments that are coming down the pipeline where someone can get a once a month injection or a once every other month injection. Mm-hmm. So one of our biggest issues right now with the HIV pandemic is keeping people on their meds, keeping them on that regimen, especially if they are part of a marginalized population that are facing poverty, that are facing housing instability, food instability, all of those things. How do you convince them that your day-to-day health is more important than you being able to eat or having a place to sleep, right? So making sure they're taking their medication every day, making sure they're coming to pick it up every month, making sure they're doing all these other things. Whereas if you're able to give someone an injection once a month or once every other month, that will keep them undetectable for an entire 30 to 60 days, that would be amazing.
Yeah, you can't forget a pill if you don't have to take a pill every day.
Yep.
That actually kind of ties into the question asked by our Dean of Students, Dave Asensio, who's asked if there's different HIV medicine based on your ability to pay. And can you speak to inequality in the healthcare and that LGBTQ plus folks receive? I think that kind of ties in perfectly because I think depending on what you can do and what you can afford, it really does impact how your care is managed.
Yeah, so I can speak to that. I'm the LGBTQ care coordinator for the Department of Public Health, and that position was just created for me several months ago after working at the Department of Public Health for about 4.5, almost 5 years. And it was created honestly simply because once I was in the Department of Public Health, and I had, I can't talk about this work without talking about, there is a doctor, Dr. Helena Kwakwa, who was the director of HIV clinical services for the city of Philadelphia, who is one of the most amazing human beings I've ever had the pleasure of knowing or working with in my entire life, who her entire objective every single day is to make sure every single person that we come in contact with that needs care gets care. And it doesn't matter your ability to pay. It doesn't matter any of that. And she enables all of us that work for her to keep that mindset, to make sure that we're doing that. So there was, there still is absolutely a little bit of a bias when it comes to care for LGBTQ individuals, even within the Department of Public Health. And hopefully I don't get in trouble for saying this, but they already know I'm loud and I talk too much. That absolutely, we have been able to more than quadruple our number of LGBTQ patients at the Department of Public Health just within ambulatory health services in the last 4 years, 4.5 years. And we increased that population by first acknowledging that there was a barrier there for LGBTQ individuals to get care through the Department of Public Health and the community health centers. Or the city health centers, I should say community. We're starting to call them that now, but they're still the Philadelphia health centers. And there's 10 of them. And in every one of them, LGBTQ individuals were finding barriers in getting their care. So what we had to do was first acknowledge that. Then we had to come up with a plan on how to address that. Then we had to find the money to be able to build out the programming that addressed that. And, there are still struggles with that. And, for a good while, my job, even though it wasn't part of my job description, but my job became knowing when there was going to be an LGBTQ patient, knowing what health center they were going to be in, and then making sure I was at that health center before they got there so that I could walk them to bypass the barriers. And oftentimes the barriers are the other staff.
Yeah.
So it would be the staff at these health centers that if this person didn't have their ID, or if their address wasn't updated, or
if their name doesn't match their ID.
Yes. All of those things were a barrier. And it's like, wait a minute, you work at the Department of Public Health. How do you not get the fact that we're supposed to be about public health? Instead, a lot of folks are their mindset is almost like to prevent people from getting the care, to find any little thing that you could turn them away so that we don't have to see them, because at the end of the day, they're getting a free service.
Yeah, well, I almost wish that things were just free services to anyone who walks in the door, and that way you wouldn't have to worry about approving or denying people. You just have it built into the budget that you can help a certain number of people per month. What an amazing idea. Who would have thought?
Right, what an incredible new idea.
What if the government funded all of healthcare? But let's not go there, because that we could be a whole other conversation.
But then we would also, honestly, there wouldn't be anybody that could not get HIV treatment or prevention drug based on their financial situation, right? Because the big drug companies, they charge us here in America $4,000 a month for Truvada. But over in Switzerland or the Netherlands or another place like that, it's like $100 a month. So the dollar amount that they're allowed to charge here versus there, which is, again, why they sink so much money into politics here. But that's a whole other discussion.
But I think there's actually there's LGBTQ organizations in Philadelphia that don't have competent trans care. And I'm sure you're aware as a trans woman how trans care is not up to snuff, because we can't even get doctors who know how to respect pronouns.
So, absolutely, that is true. That is also true. Again, I'll speak from my own experiences, but that's true with the Department of Public Health. That, it's another reason why I was having to show up at the health centers when I knew there was a trans patient, because I knew that they were going to get disrespected. And as we all know, that is a barrier to receiving your health care. So
Absolutely.
yeah, and there's absolutely organizations in this city that still do not make sure that all of their staff are properly trained, still do not make sure that there are policies and procedures in place to protect particularly trans individuals that come in for care, that do not make sure that their waiting rooms are safe for them, that do not make sure that when a trans patient walks in that they see themselves there. Because we talk a lot about
Hmm.
representation, but walking into a healthcare facility and seeing some posters on the wall about HIV meds and about Truvada and about this group and that group, but you don't see yourself anywhere, that's important too.
Yeah, if every flyer only has white gay men, you're missing out on a huge chunk of the population.
No,
And
well, it always strikes me as funny when the flyers have white gay men, but then you look in the waiting room and there's no white gay men.
yeah, absolutely. I think that's the other
Yeah.
thing is that there's once you reach a certain economic level too, you also have access to private doctors. And so like community clinics don't are not full of people who have access to great medication. They're people who are on waiting lists waiting for months to get access to
Yes.
these free community services. And so marginalized communities are the ones who are going here. So you have people of color, you have trans people, you have all these different communities coming, immigrant communities, and you need to train staff how to handle people from those communities and how to respectfully interact with people from those communities. So I think one of the big things is I think that LGBTQ organizations think that people who are part of the LGBT community or people who are applying to work at an LGBT organization will automatically have LGBTQ competency for all like marginalized groups within the community. And it's like, just because you're part of the community doesn't mean that you're well educated in every nuance of the most marginalized folks within that community. And so there needs to be
Hmm.
training that's done regularly.
Yes. Or look, I hired one, so that means that we are LGBTQ competent.
Hmm. Yeah, it's like
That's not
we
how it
hired
works.
gay and lesbian folks, but we didn't hire any trans folks or any agender folks or intersex folks. So we're just gonna call this diversity. Oh, here's a great question from Dr. Curry, who runs the Women's Outreach and Advocacy Center at CCP. Is the incidence of AIDS higher amongst people of color?
Absolutely. Absolutely. Without a doubt. And as we all know, there are a lot of factors that play into that. You know, your poverty rates, housing instability, education, all of those things play a part into that. And whenever I bring those things up, I want to make sure that I redirect it and acknowledge the fact that it is not just because they're black or they're brown. It is because we live in a country that still values people um, with lack of pigment in their skin more so than we do people with pigment in their skin. That is why the poverty rates are higher. That is why the barriers to care are higher. It's not because they're more promiscuous. It's not because they're lazy. It's not because of all these things that you would have certain groups of people try and make everyone believe. It is because they are not given the same opportunities and respect that that the rest of the populations are given. So that's why you see, higher rates.
Yeah, I mean, plus if you're getting your medication from a clinic and you have to switch clinics and now you're on a wait list for 3 months, you're going 3 months without medication.
Yeah,
Um,
absolutely.
and you condoms are expensive, like prophylactics are expensive. So there's also a financial barrier. So marginalized communities that experience financial marginalization because of like generational wealth and wealth inequality and income inequality and discrimination in hiring, like all those things compound, especially financially, and become issues in getting access to care and getting access to treatment. And like I think AIDS is also a lot less common. Like a lot of times HIV is able to be treated and controlled by medication. So
Mhm.
it doesn't really develop into AIDS unless you're not having continuity of care or you have a medication resistant strain of HIV that you have to now switch your medications, but you're not seeing a doctor regularly. So I think that you definitely see AIDS in higher instances in groups that are not having access to healthcare in the same way.
Yeah, absolutely. And, that goes for the immigrant communities. And when we talk about immigrants, a lot of folks only think about like Latino immigrants, and there's Caribbean immigrants, and there's, Asian immigrants, and there's all these immigrant populations have a really hard time as well. And, if we just simply allow anybody who's here to have access to the things that they need, that is not anybody saying, hey, let's just take care of them. Let's give them all a bunch of free money. Let's give them. Mm-mm.
Mm-mm.
Most people are willing to work hard for things if they have an opportunity to do it.
Yeah.
Like my first job, I had to do survival sex work for a number of years. And, that wasn't easy either. And so my first job was at a community-based organization here in Philadelphia. Well, it wasn't my very first job, but it was my first way of trying to get my way out of having to do survival sex work. And when they hired me, they would only pay me for 10 hours a week. And I was told that the only thing I was good for was to go out at night around to the bars or to the stroll where other people were doing survival sex work and give out condoms. And as people started to get to know me and started to talk to me, I started getting invited to places and into rooms and into situations. And then every time I would show up at one of these events or show up at one of these things, I would get called into the boss's office at this organization that I worked for and told that my job was on the line because that is not what I was supposed to be doing. I'm like, but I didn't do that on your time. You're only paying me for 10 hours a week.
Yeah.
Well, you're
You
representing
definitely don't
us.
own my life if you're only paying me for 10 hours a week. I'm sorry.
Right. And then it would be like, well, you're representing us. Well, wait a minute. If I'm going out after my technical work hours and doing things, I'm representing Deja, Lynn, Alvarez and my community. I'm not representing you. If you're going to tell me I'm representing you, then you need to start paying me for a whole lot more hours.
Mm-hmm. Absolutely. Oh no, it seems we've frozen again. Well, hopefully Deja will unfreeze. Oh, there you go. You're back.
Oh, there we go.
All right.
That's what a lot of folks tend to do. They tend to hire someone and just kind of put them in this little box instead of giving them the actual chance to show you what they can do. And I think we see that a lot in the marginalized communities. There's a lot of stereotypes.
We have another follow-up question. Mm-hmm. In the past, I heard talk of AIDS amongst the senior population due to relationships with younger people. Is this still a given? If so, what is the incidence amongst seniors?
So the talk of AIDS HIV and STIs amongst senior populations, as far as from a public health perspective, it is not due to relationships with younger people. It's honestly due to the relationships with each other, where for some reason they kind of have the opposite of what the young people had, that mindset where I'm invincible. And I think when they hit a certain age, the seniors
I'm on the way out anyway.
Yes. So what we've actually seen is in some of the senior care facilities, we've seen a spike in STI rates all across the board, not just HIV, but in chlamydia and in syphilis and herpes and all of those things. So we've actually been trying to work on ways to address that and to have conversations with seniors who just feel as though they can't get anything.
Yeah. Well, so I have one more question, the last question of the day, and then we're going to pull up our slideshow again. I apologize, folks who joined us early and saw the slides moving too fast. I'm going to play the slideshow again at the end with slowed down slides so you can actually read each one. But our last question for Deja is, if anyone watching wanted to get more involved and volunteer for a local organization combating the HIV epidemic, where do you suggest they start?
If you're not from the LGBTQ community and you're not looking to just get involved with LGBTQ individuals, then honestly, I would just look up HIV services and clinics around the city, because not all of them are focused on LGBTQ people. Absolutely. And it would depend. I would honestly say figure out what you're really passionate about as far as HIV, and if there's a particular community. A lot of people want to help folks that are in active addiction, and so there's specific places for that. There are specific places for LGBTQ. There are specific places set up now around immigrants and HIV. So honestly, I always say Google is your best friend. Use
Yeah.
Google, look up a bunch of different organizations, look up what is being said about them, and then find a way to contact them and see what kind of response you get from them.
Yeah, absolutely. Thank you for that, Deja. Thank you for joining us, and thank you for being
Absolutely.
our sole panelist today. Unfortunately, our other two folks got called away. So thank you for doing the heavy lifting of answering all the questions. And so now
Sure.
we're just gonna go over to our. Let me share my screen so we can start this slideshow. So yeah, thank you, Deja, for being here.
Thank you.
And I look forward to seeing you again soon. And
Yes,
thank you all
hopefully.
for joining us. And please enjoy the slideshow as we close out this event. And thank you for joining us. All right.
Everyone have a good, safe week.
All right. Bye, everyone. All right, thank you all for joining us. If those slides were moving a little too fast, this video will remain up after we end the live stream, so you can always go back and watch it again and pause for each slide if you missed some of the things as they were moving by. But thank you again to Deja for joining us today and holding down the fort when our other two panelists were not able to make it. And thank you all for tuning in, and we hopefully will see you at our next event. So please check out the Pride portal for future events. Thank you, and have a great rest of your day.